So just really quickly, just a little synopsis of the difference between the neurodevelopmental approach and traditional modalities and therapies. Basically, traditional therapies are targeting the symptom, where the child is, what their age is, and where they should be. The neurodevelopmental targets the underlying root cause of the symptoms and not where they should be based upon their age, but where they should be in development based upon where their development has already brought them to. An example would be, very typically, if a therapist gets a child who's 4 years old and they're not walking, they feel like they need to get that child up in a stander and standing because they're 4 years old, they should be walking. However, that's the last thing a neurodevelopmentalist would really do, because our training shows us that if a child hasn't gone through the traditional steps of development, their physical body is not ready to go into a stander and support and bear weight. If you do not go through the traditional stages of crawling and creeping, which most brain injured or CP children have not, if you have not gone through that, you could actually be running the risk of dislocating hips or having the hips displaced. When you're born, you are not born with a hip socket. You are born with a ledge that will become the hip socket. And so as that baby crawls on the belly, that femur head is pounding into that shelf every time it makes that movement. And it actually develops the hip socket. If that has not happened, you start weight bearing, you start standing, you could dislocate those hips very easily. That happens a lot with the Down syndrome population because, unfortunately, our children tend to like to do it the wrong way. They roll, they scoot. They don't always crawl and creep like they should. So we really look at where has the development brought that child to what point, and then picking up at that point and bringing the child to the next step, as opposed to, oh, this is their age, this is what we should do. Traditional therapies think it's just like the most important thing in the world to sit. Neurodevelopment, and I've seen that across the North America. Neurodevelopmentalists think the most important thing is to crawl and creep, and we'll talk about that in a minute. So we look at root cause rather than symptomatic. We are non-invasive. We do activities that stimulate the brain rather than activities that go in and say a child is starting to dislocate hips, is starting to have some problems. We have a whole host of activities we do a lot of to try to bring it into place, as opposed to some of the terrible surgeries that are often given the options. Traditional therapies, you might go to a therapy twice a week for half an hour. We don't believe twice a week for half an hour is enough stimulation to the brain to make the change. So if you are not following up at home with the exact specific activities that therapist is doing, we don't feel like you're making enough input to the brain to change the brain. The neurodevelopmental, we teach the families how to work with their child at home. You don't have to go to a therapist if you don't want to. You don't have to drag all the kids out 2-3 times a week to this therapy and that therapy. We give you the tools. We teach you how to work with your child at home. And you're doing it 5 days a week, which is ample stimulation to make a change. Some things we might do 7 days a week. Some things maybe 4 days a week. But we do it enough with enough consistency that week that stimulation is going to make a change in the child's life.
Just with Garrett is a prime example of root cause treatment versus traditional treatment. With the traditional treatment, we were told to allow compensation for him, coping techniques, and he was, again, on the 3 medications. Garrett had a lot of anxiety, and he was slipping into depression. He was having lots of symptoms of chronic depression. And what we discovered was, through the neurodevelopmental approach, was that the anxiety and depression were a result of him having to bring in too much sensory information. He was always in a state of agitation. His hearing was too sensitive. He was bringing in too much visual information. His skin always felt like it was just crawling because of tactile sensitivities. He was not able to process the information appropriately, and that put him into a state of anxiety and depression. And through our experience, we've noticed that, or noted that a lot of people that have the traditional OCD kind of diagnosis or generalized anxiety or depression, it's actually neurological disorganization that's creating the anxiety that can push a person into depression. And once we address the root causes, got Garrett's brain hearing more appropriately, seeing more appropriately, feeling more appropriately, smelling more appropriately, all of those areas diminished, became more normal, and he would come off all the medications. He didn't need anti-anxiety meds, he didn't need antidepressant meds, he didn't need the Ritalin to stay focused and to maintain impulsiveness. He was able to control that himself. He had the ability, the brain organization to do that.
That's exciting. Okay, just very quickly, for lack of time, I did want to show you the developmental tool that we use to assess children. At the very top of the profile, you'll see the modalities that we work with: gross motor, expressive language, fine motor, visual, auditory, and tactility. The very first level is where, again, just a step above comatose, and then as the body gets stimulation in, then you start developing up the spinal cord. There are 3 levels of input and 3 levels of output. And because of this profile, this is a tool we use to find the root causes of what is going wrong and what is not happening. So when a child comes to us, basically, we will start slashing the levels of development that they have not completed. And they can come in at any age and have some of the very primitive, very beginning levels of development still not completed.
And that can be like kids with just like learning disability labels, like just basic kids. I've seen kids coming in with like a reading problem or dyslexia, not having proper light reflex, not having proper Babinski. They're startled. They may still have a startle or a word reflex, like not obviously like a newborn baby, but it's still there. It's not inhibited.
So this is a tool that our organization uses. It's based on the original profile that goes back to the 60s. We've expanded it a little bit to show a more realistic look at the tactility section. We've also expanded it and put on some accelerated levels, because for the only age reference we make, if you start at the top, level 1, 2, 3, 4, 5, 6, 7, where the big strong line is through most of the profile, that's the bottom of level 7. The average second grader or 7-year-old should be completed all the way through level 7 with no slash marks on it. And we see children of all ages coming in with very similar to this kind of a profile. So in our culture, we're not inputting and going through getting development to happen like it should. So, and again, the neurodevelopmental helps at any age. At any age. In fact, if you know someone who's had a stroke or traumatic brain injury from a car accident or a bike accident or something, they need neurodevelopmental dramatically, because they've lost the organization of their brain in their central nervous system through that trauma, and the only way they're going to have the best shot at recovery is by going back and reorganizing the system.
You guys have probably all seen on television shows, someone comes in with a brain injury and they go along the bottom of the foot, and what they're checking is called the Babinski reflex, and a newborn baby splays out. Very soon after it develops, and you go along the sole of the foot, you move in. When you have a brain injury that actually impacts that area of the brain, then you get your Babinski back, it pops up again. And that would be significant of a fairly serious brain injury.